Good afternoon, everyone, and welcome to our third weekly town hall being co-hosted by the Perinatal Neonatal Quality Improvement Network of Massachusetts and the Betsy Lehman Center for Patient Safety. I'm Barbara Fain, the Executive Director of the Betsy Lehman Center, and we're delighted to be partnering with Pinkwin on these virtual forums for exchanging up-to-date information about COVID-19 and pregnancy care. So we have a packed hour coming up, and I'm going to quickly turn things over to Ron Iverson, who together with Audra Meadows co-chairs the Massachusetts Perinatal Quality Collaborative. A few housekeeping items before I do. If you're having technical issues, please just send a chat to Alex Zhang. You can also send chat questions as we go for the speakers for later on. And please let us know if your question is directed to a specific presenter. And finally, just want to mention that this meeting is being recorded and chats are as well. So if you have any concerns about the recording, you can just send a chat to the Betsy Lehman Center. So without further ado, let me turn this over to Ron.
Good morning, I'm Ron Iverson. I'm co-chair of the Mass Perinatal Quality Collaborative and Pinkwin with Audra Meadows. And welcome, thank you again for calling in today. We are excited to share some more projects that have been going on around the state, a little bit about implementation, a lot about final results, and we hope you all learn from this. Our next speakers are going to be Madge Buss-Frank and Joanna Salenza, who are going to be talking to us about co-production during COVID-19. We're really excited that they're able to join us today from north of here up at Dartmouth. So thank you so much.
Thank you, Ron and Barbara. We are absolutely honored to be here. And I'm delighted to be presenting with a family partner from the Children's Hospital at Dartmouth and a March of Dimes Family Support Specialist, Joanna Salenza. Next slide, please. So the challenge that we were asked about is co-production even possible in a crisis, especially a crisis like COVID? And so I thought it would be a good place to start to just level the field to talk about what co-production is, and perhaps to make the case that co-production is even more important in a crisis situation. Based on some of the work done here at Dartmouth by Glenn Elwin and Jean Nelson, this is what we would call the co-production cycle. But in plain speak, it's really simple. It's just same page care. So it begins at the top with this idea of two experts in the room, the care team being one expert and the family being the other expert, and sort of beginning by co-assessing how do things stand? What is the current status? What is most important to you? Meeting this patient, no matter where they come from, what their situation is, where they are in that moment. The next step is something I know all of you do every day. It's co-deciding on what are the next logical steps, but really based on the patient's goals, infused with your expertise and options for that patient, comparing those options in order to help the patient make informed preference-based choices. The third step is that co-designing a plan that will fit for this patient, this family, this circumstance. And thinking about equity here is really extremely important. And then the third step would be co-delivering. How can this patient contribute to their own well-being and care? And what do we need to do to support them in being successful? Next slide, please. The challenge really is that co-production or same-page care is always challenging, even in the best of times. And we often find it easiest to do with people that are a lot like us. It becomes more challenging when we're dealing with socially complex and fragile families, like many of the families we see here in New Hampshire in a remote rural area, but the same things would apply to an inner city circumstance. Imagine if our government had co-designed the approach to COVID with actually family and patient partners at the table, that drive-through testing might not have made sense for if they didn't have a car or had to take a bus. Or imagine if they had co-designed the solution, the relief checks, with folks in mind who might not have a bank account or might not have filed their taxes, how we could have avoided a lot of speed bumps and perils along the way. I don't want you to make those same mistakes as you're designing and redesigning your system of care at the speed of light. So I wanted to pause for a quick poll here, if Barbara will bring up the poll, and just ask you to take 30 seconds to reflect. If you can pull up the poll question. To what extent have families or family leaders been engaged with you during this crisis as allies in thinking about the system level changes or solutions? And be honest, we are in a crisis. Have they been completely engaged and really full members of your unit level task force? Somewhat engaged? You might have asked for their help or guidance on certain aspects of what's happening, or not at all engaged. Things are moving so quickly, we simply haven't had the time or energy to do this. And you can see the results coming up here. It looks like a lot of people falling into the not at all engaged category, and that's understandable. No criticism here. So let's move on to think about how we might move forward at this time. So we can have the next slide, please. And the poll can go away. And think about what are some very practical changes that you might test in this circumstance. So for this aspect of the program, I'd like to ask Joanna Salenza to jump in. She has been working in the Dartmouth nursery for nearly 20 years. And this relationship of co-design has evolved over time. She has a couple of innovative snapshots of things you could consider to try. And so Joanna, talk to us about what it is you're working on right now, along with the medical and nursing and leadership team.
Thank you, Madge. Next slide, please. So I'm a family partner in the intensive care nursery. But the one piece I don't want to neglect to mention is that I'm blessed to work with a team that really embraces family partnerships. And when I talk about family partnerships, I'm talking about at the bedside, really collaborating with families, but also engaging with family partners at a more systemic level. So this very quickly, I want to keep to our time here, which is limited. I'll talk really quickly, but feel free to chat in questions. One of the things that came up was as I started to work remotely, I am an embedded member of the care team, but working remotely means that I am not able to sit with families. So within a day, I was set up with telehealth and the ability to meet with families. So this is very quickly progressing. I'll be testing different ways to implement telehealth through my role of education and support. Let's go to the next slide, because the other piece of my role is that of really working with advisors. And many of us are at the receiving end of policy changes that we maybe have nothing to do with, but have to explain to families maybe why their support network can't be with them at the bedside. So what this is just a really quick snapshot of some of the messaging that had to be put out there, but we really wanted to explain this to families and give them a context and let them know that they're essential partners in the care of their infant. So through our advisory council, which is a web-based council, we were able to very quickly turn some patient-facing communication that was hopefully meaningful to families. Could we go to the next slide for Madge to wrap this up?
Yeah. Joanna, I'm so impressed with the idea that you'll be doing telehealth visits with families, scheduling them, making yourself available sort of weekends and evenings and times that might be best for families. And we're really interested in the metrics that you'll bring forward about how families use it, how useful and helpful it is, and the really sensitive and keen eye that Joanna has for assuring that this should be available to every family. even in rural New Hampshire where our internet goes in and out as the wind blows. So I would just sum up the thinking. These are a couple of hors d'oeuvre morsels for you to think about whether they could take hold. These ideas could take hold in your unit. But I would say no matter what you do, now more than ever in a crisis, patients, families, and your team members don't want to be acted upon. They want to be in partnership with the rapid changes that they're being faced with. And so if we think about this idea of co-production and co-design, moving from complaining to giving information to listening and responding would be a really great goal. And as you can, thinking about families consulting and advising on communications that are going out, assuring that everyone's safe, but the language isn't as scary, and that we're moving towards that continuum of true collaboration. So as always, families are the ultimate arbitrator of the quality of care that we give, and Joanna has a quick quote that she's going to send us off with.
I don't know that it's a quote, more as just a reminder that in order to really remember the difference between family focused care, which is doing for families, which I think we all do really well, remembering that family-centered care and really supporting families is doing with. So it's that distinction that I think that's important to remember during times like this. And I just applaud all of you for the effort that you're putting into really thinking about all of this. So with that, I'm going to throw it back to Madge for the last resource slide so we can move on to hear about the next speaker.
Great. We put together just a few resources that were really awesome. The Academy of Communication in Healthcare has some wonderful vital talking scripts that have been fully tested in partnership with families, and there are a variety of resources here we hope will be helpful to you. And of course, we'll hold questions for now, but we're happy to engage in the dialogue after we've heard our other esteemed presenters. So it's my pleasure to introduce the next speaker, Sarah Ray Easter, who is going to help us navigate critical issues for critically ill COVID patients.
Thank you so much for that wonderful introduction and the opportunity to follow such a family-centered talk. I think, you know, it may seem like a bit of a leap transitioning from family-centered care to critical care, but in essence, they're the same thing. I think a little bit of the purpose of my talk is to acknowledge the increasing prevalence of critical illness in pregnancy that we're seeing. You know, I think for all physicians, intensivists included, independent of pregnancy status, it's a really stressful time. You know, there are new updates every day that happen about a disease that we just don't quite fully understand. And we're asking to sort of integrate this knowledge under new standards of care that are being modified both to reflect the limited resources available in our system and then also the need to prioritize healthcare provider safety. In contrast, critical care for pregnant patients is always stressful. Perhaps the OBs are the least stressed patients caring for critically ill pregnant patients, in part because it's just different. The physiology is altered, and I think the presence of the fetus and that sort of interplay between mom and baby that we are so comfortable with on labor and delivery can really throw a wrench in the care of even the most seasoned intensivists. And I think one of the real challenges that we are facing is that every day new standards of care are emerging. And I think there's no sort of real set point of what care we should be providing. That is stressful in general, but I think it's even more concerning when you think about how women from at-risk populations may be sort of differentially impacted by the absence of a standard of care. Next slide, please. So I think my hope is to actually outline a little bit of the process of trying to create a standard of care for critically ill patients at your institution. Advance. I think, you know, you have to acknowledging both that provider comfort with critical care and or pregnancy, depending on your background, is variable. And I think, you know, recognizing that clinical care in this environment doesn't mean taking care of just the patient or her family. It also means, you know, acknowledging the anxieties of the provider tasked with dealing with a baby inside of this critically ill patient. And I certainly feel this in my day-to-day life, but, you know, clinical care is one piece, but the clinical operations surrounding it pose a different challenge. If you'll advance one more, I think that you'll recognize that there's a wide range of stakeholders involved, whether it be physicians or nurses in the intensive care unit or on labor and delivery. We're responsible for sort of coming together as a team that speaks a different language to work towards a common goal, even if we are approaching it from different perspectives. And we have to integrate opinions of others along the way. If you'll advance, I'd like to, hopefully propose some resources in this talk that talk about ways to standardize processes, but allowing room for individualizing care, and to integrate some of the multidisciplinary perspectives at play. The goal is to sort of set forth a path that perhaps would be that you could easily navigate for patients that end up in your ICU in the era of COVID. If you'll advance the next slide, I think one of the biggest issues that we're encountering is actually trying to standardize a process for evaluation. This is just one framework that we found really helpful to share widely with ED providers and with our nurses in clinic to make sure that people are all operating from the same playbook when it comes to who should be in to be evaluated, who should get admitted, and then when admitted, who should be considered for transfer to the intensive care unit. If you'll advance to the next slide, you'll see that when patients are admitted to the ICU, we're finding that it's a huge amount of bandwidth to sort of go through all of the things. You can give every medication in pregnancy except NSAIDs, fluoroquinolones, and doxycycline, we say. Sedatives are safe, paralytics are safe, pressors are safe. And I think sort of repeating that talk over and over again became a real challenge. So we actually came up with this sort of 2-page quick tip for the intensivist caring for a critically ill pregnant patient that's organized in a framework that they would use for their rounds in vocabulary that's familiar, sort of highlighting some key differences in both medications, hemodynamic targets, and lab parameters for the pregnant patient. Next page. I think that you have to recognize, though, that education goes both ways. It's not just our job as OBs to try to provide some education for our intensivist colleagues, but actually we should demand that our intensivists provide a little bit of an education for us so that we can understand what they're talking about when they're talking about increasing the respiratory rate to address her latest ABG, or when they're worried about the adequate PEEP in pregnancy. It's okay to be humble. It's okay to ask, hey, can you provide me of a little bit of a reminder of this? I've not thought about, vent settings in quite some time. And I think trying to not only, provide that type of multidisciplinary education, but also demand that really sets a framework for being willing to be humble, learn, and come together in the best interest of the patient. If you advance to the next slide, I think another key point, in addition to the education piece, is providing a lot of clarity in communication. This is an example of like a one-pager that we walk over with when we have a new patient admitted to the ICU that we post outside of her door that gives us sort of the contact people with their pagers and sort of the various reasons that we would call. If she's coding, it may not be the right time to call the senior OB on call. But if you stat page the OB attending out of a delivery for the critically ill pregnant patient to ask if NSAIDs are safe, that may not also be appropriate. I think importantly, we've set forth some clinical criteria that we would suggest for notification clinical status. This is to acknowledge not only some of the different hemodynamic targets for pregnant patients, but also to try to give some attention to, providers caring for these patients who may be nervous about the possibility of, pulling back the sheets and finding a baby in the bed. So how do you diagnose labor in a sedated and paralyzed patient, for instance? I think it's important to emphasize that these are sort of general parameters and that we'd rather be called than have people make decisions in isolation. If we can achieve this PCO2 target without, exposing her to additional volume-associated trauma of mechanical ventilation, perhaps it's not worth it, and we should have a discussion about it. If you advance to the next slide, I think a similar framework can be seen for sort of critical pathways, right? The notion of delivery for sort of spontaneous delivery is one thing to worry about, and making sure having sort of a NICU warmer and a vaginal delivery kit at the bedside is an important piece for every critically ill pregnant patient. But going through the actual, indications in which we perform a C-section and sort of what those pathways might be. This is a Brigham-specific algorithm, but I would argue that you could call and adapt this easily for any environment. I think emphasizing the maternal cardiac arrest pathway and the fact that C-section is an important part of that that pathway is really important. The idea of making an incision by 4 minutes of a resuscitation to have a baby out by 5, and emphasizing that that's not actually for baby, but that's for mom to improve her outcome and chances of return of spontaneous circulation. If you advance to the next slide, you'll see an even more developed framework for a stat C-section from our ORs, recognizing that where our COVID ICUs are located is very, very far from labor and delivery, 2 city blocks away. And so, we developed sort of parallel pathways that we're drilling every Wednesday morning with the OR team to try to prepare for this low frequency, high acuity event. If you advance to the next slide, I think that we, in theory, could be able to put up a poll to ask, about a patient that we've been caring for recently, a patient who was admitted, a Hispanic but English speaking, G1P0 presenting at 32 weeks with hypoxemic respiratory failure requiring intubation and paralysis. Unfortunately, she developed a DVT, and then a little later on in her pregnancy, ruptured membranes. And interestingly, as she progressed towards extubation, being on a therapeutic heparin drip, her care became suddenly more challenging. If someone from the Betsy Lehman Center is able to put up the poll, I'd be curious to know what your plan would be for this patient who's getting ready to be extubated, recognizing that she also needs to be on therapeutic anticoagulation. Would you just section her outright? Would you hold on until 34 weeks and follow the standard of care? Would you induce her before you pull the tube? Would you wait until you do it after the tube? And I think, ultimately, or at least hopefully, the plan isn't actually that straightforward. There's a lot of considerations at play, and I think different institutions, different providers, different scenarios will be answered in a different way. Our plan, interestingly, was to actually induce her prior to extubation. She actually developed choreo with a big bradycardia, and so the baby's plan was for a C-section, and we went with that as well. But if you advance to the next slide, I think the actual management of this matters a little bit less, and it's more about the framework. This is sort of a 2-page checklist that we developed that, again, will be available to share as a resource that actually goes through sort of standard indications for delivery, standard components of critical illness, and routine parts of what we do every day on labor and delivery that warrant special consideration. For instance, is she a candidate for Methergen? Is she a candidate for Hemabate? What about terbutaline? When did she last get steroids? Simple things that we do every single day that may get lost in sort of the complexity of care, or that may be totally foreign and completely intimidating to an ICU team. So this resource, I think, can be really helpful, highlighting not only sort of the specific parts of the care plan, but the parts at the end where we're saying, what are the outstanding contingency plans we need to make? What are some of the additional clinical questions? And when are we going to meet again to talk about this and update according to our clinical status? So if you'll advance to the next slide, I'd like to sort of summarize by saying that, there is room in the critical illness space for both clinical care and clinical operations. I think these types of resources that are available can minimize errors and are meant to inform and sort of enhance clinical care, although I recognize it's an oversimplification of a complex problem. I think most importantly, this is a framework to start a conversation. It's a guidepost for which to sort of hang future twists and turns in what is a very complicated course. And I think, tools like this really champion a multidisciplinary perspective that leaves a space for providers to offer their opinions, to contribute to care, and really not only sort of focus just on the outcome, but the process to get there, with the idea that sort of each iteration of this checklist, of this protocol, will inform care for the patient that comes behind her. I think importantly, this is a really wonderful framework to ensure that patients receive equitable care, that, patients who are perhaps marginalized because they are not English speaking, or have limited health literacy, or have social circumstances that make it really challenging them for either present to care or stay for risk appropriate care. Those patients are being cared for in a standard way where really no standard of care exists. And so if you'll advance to the next slide, I'd like to close by expressing gratitude to sort of the multidisciplinary team members who helped develop these tools over the past few weeks. And I'd also, include a plug not only for sort of for my availability if there's anything I can do to help answer questions. But as a reminder that actually what we do on labor and delivery is not that different than what we do in the ICU. I promise you that titrating, a Levophed drip to a MAP of 65 is a whole lot easier than titrating an oxytocin infusion to an entire separate human being. So with that, I hope that you will go on to be empowered and confident and find some utility to adapt these frameworks to your local environment. And then I think I have the wonderful opportunity to introduce a speaker who I'm sure will teach me a fair bit, both about breastfeeding and rooming in during the COVID-19 pandemic. Dr. Parker is an associate professor of pediatrics at BMC, and I look forward to the pearls that she has to share for this group. Thank you.
Perfect. Thank you guys so much. I think that Ron first asked me about a week ago about this presentation and wanted me to focus on breastfeeding, but I quickly realized late last week that the whole conversation about rooming in versus separating is very integrated with the breastfeeding safety question in the COVID-19 pandemic that we're dealing with in newborn care. So I've decided to make my talk about both of those two topics. Next slide. Okay, so right now, I think what makes this so challenging for those of us trying to come up with safe plans for newborn care right now is that the risks and benefits are really unclear of what to do. So with respect to breastfeeding, we know that breast milk confers antibodies and bioactive components that can be protective against infections, and we've seen that over and over again. However, there also are viruses that are known to be transmitted through breast milk. And so it's possible that COVID-19 could be transmitted in that way. It's also possible that the process of the actual breastfeeding itself, that means like the baby touching the mother repeatedly and putting saliva on the mother, etc., is another way that COVID-19 could be transferred. Now, with respect to the rooming in versus separation debate here. So we know that rooming in allows mothers to bond with infants, and it allows mothers to establish breastfeeding. So meaning they're able to practice breastfeeding for the very first time ever, especially those primips. And we can do it in the hospital environment with lactation support. But again, we are concerned that doing this can increase the chance that infants may become infected with COVID-19. On the flip side, we could do separation of the mother and the infant after birth. So this clearly is going to decrease the risk of transmission of the virus to the infant, but it precludes the establishment of breastfeeding with hospital lactation support. So we're really stuck here about what's the best thing to do. Next slide. So, we are confused, but it turns out professional organizations also make it confusing for us on the front line. So we've been finding our professional organizations differ in their recommendations on these two key topics. So the WHO recommends rooming in and direct breastfeeding with precautions. However, the AAP, they have come out with statements at least a couple of weeks ago that recommend separation and no direct breastfeeding if it's possible at your center as a first default, and then only then to do rooming in if your center is unable to offer separation. Last, we have the CDC, which is recommending a shared decision-making approach with families and consideration for direct breastfeeding and rooming in versus separation on a case-by-case basis. So they're suggesting that we talk with families about the risks and benefits and then make up our best case judgment about what we should be doing. Next slide. So, we were interested in knowing what have our hospitals in Massachusetts been doing so far with all of this information. And so I'm one of the associate directors of our NeoQuick collaborative, so our neonatal quality improvement collaborative. And we conducted a practice survey and we had 28 hospitals respond. And you can see we did this the very first week of April. And at that time, we asked about breastfeeding, and about a third of hospitals were saying that mothers could only express their milk and give it to infants. And 2/3 at that time were still supporting direct breastfeeding with precautions. With respect to the rooming in versus separation, we found about a quarter of the hospitals at that time were making separation the default strategy, about a quarter were having rooming in as the default strategy, and about half were doing it on this case-by-case basis in consultation with the mother or the family's preferences. Next slide. So I just want to have a point here, a pause about health equity. So breastfeeding is very important in this area. It's considered a modifiable health behavior that can offset adverse health outcomes for mothers and infants. And we know breastfeeding occurs less often among low-income mothers and African-American mothers in particular, which means we actually should be supporting breastfeeding as much as we can in these populations. However, COVID-19 occurs more often in low-income populations, underrepresented minorities. So again, we're sort of stuck with a debate about what to do with rooming in and breastfeeding in this area. Next slide. So now I wanted to segue to what's happened at our own center and kind of walk you through the process of like real life, like what has really been happening with all of us talking and trying to do so much in such a short period of time. So at our center, so far, we've had 13 COVID positive mothers that have delivered since March 31st, which is right about the time when we started the testing. Of those mothers, we've actually had 5 infants that have been positive themselves, which we recognize is higher than most other reports that we've seen. 5 infants have been negative, and 3 infants currently have their tests pending as of last night. I didn't check the charts today. And interestingly, all 5 of our positive infant cases have been born to Hispanic mothers, and I believe all of them have been multips as well. So, you know, what happened for us? How did we address this issue of breastfeeding and location of newborn care at our center? So we were really stuck with 2 really important questions here. What do we ourselves think is the right approach? Meaning there's really no right approach, but what did we think was the right one? And second, how are we going to actually pull this off? How are we going to make it work, considering the workflow and the different types of personnel and the way our system is set up? Next slide. So I'll kind of walk you through what we've done in the last 3 weeks. So this is just a list here of those 13 cases that I described. So the 13 cases of mothers that have delivered that were COVID-19. So first you'll note I'll walk you through this. The case numbers are there. And then I tried to discern it and organize this. So trying to understand, were mothers' preferences about rooming in versus separation actually even assessed? And then where did we initially admit the babies? You can see they're almost all the NICU. Where were the babies discharged from? And was there any breastfeeding that occurred? And then again, that's just what I said, what was the infant status with respect to COVID-19 at discharge, and then some notes. Next slide. Okay, so you'll see our very first case here. So I'm fairly sure this mother's preferences were not assessed, although it's possible they were and they weren't written in the chart. So in the very beginning, when we started this, very early April, in our minds, we were like, oh, safety, we must separate these babies right away. That's definitely the right thing to do. So this first case was actually a mother who spiked a temperature in the PACU. And so the mother had already initiated breastfeeding and had done skin to skin. And then we came in and told the mother that the baby had to be removed for its safety. I wasn't there for that particular conversation, but I was there for another one that happened the week prior for a mother that ultimately was a PUI and ruled out. And I can tell you that was an extremely traumatic experience. And I am used to giving sad news, unexpected news to parents about things that happened to their babies. And this was pretty, it was very emotional and intense, both for me and this mother, to tell her this. So I think that these experiences really hit us as a team, as for us to be thinking, you can do next slide actually. What is the right thing? Okay, so again, we had cases where mothers became PUIs after birth and rooming in had already occurred. So number one, we just felt like this was very traumatic to do these to families. And we also recognized like we were having these cases where the moms were already with the baby, then became PUIs. And so then we separated. And so then we were wondering, like, it was pretty arbitrary to separate the infants that had already been exposed to the mothers. So I think this sort of opened our whole understanding about like what is the right thing we should do. Ultimately, as a group, had a consensus that the rooming in versus separation based on a case-by-case basis was more appropriate and resonated with us as a group at our center. Next slide. So what did we do to try to achieve that? So we worked on this really hard for a couple of weeks. We still are. So we have tried to have an approach to work collaboratively and offer rooming into mothers versus separation. So again, I won't go into all the details, but this involved a lot of coordination, both by our NICU and our nursery team. And this is really like the nursing leadership and the physician leadership, and really trying to understand how we can keep a couplet together with both the mother and the baby, both under precautions in the same room safely. And that has been pretty challenging for us to think about. We developed criteria for rooming in. So examples would be, of course, the mother herself can't be that ill. The baby can't be that ill. We want to have another caretaker in the room to help with the baby. So things along that line. We also had to totally rethink our discharge coordination practices. So how do we do circs and hearing screens and red reflex testing when a baby is under precautions and we don't want to share like the audiology equipment, for example, from baby to baby? So we've had to rework how we're doing all of those things. Finally, with respect to lactation support, our lactation consultants have really banded together and come up with a lot of different support documents and ways to talk to moms about their unique needs in this time of separation. So stuff about the cleaning and expression and that kind of things. And I have all those materials, and we can certainly make them available for other hospitals. Next slide. So you can see, I'm very excited we had some successes. So you can see I highlighted the 3 times when a baby first came to the NICU. Then we went about talking with the mom, understanding if she wanted her baby to be in her room with her. And we were able to transfer the baby from the separated environment in the NICU into the mother's room. So we successfully achieved rooming in. You can see that in all 3 of those cases, the mother did successfully breastfeed. So we feel that that was definitely an accomplishment for our team. Next slide. So one thing I wanted to bring up that I think is very interesting is this idea of a balancing measure. So whenever you're doing your quality improvement work, you want to keep in mind what is your outcomes and then what could be unintended consequences of those goals. So I think this is an interesting one. So we've had 2 cases where the baby was separated from the mother, placed in the NICU, and then in the NICU we have these babies on these continuous monitors, and the monitors pick up all kinds of things that are probably happening in the nursery where they're not on monitors. So in the nursery, we had 2 cases where the babies had DSATs that we felt were significant enough, meaning less than 80%, that lasted for more than 5 seconds, where we would consider these quote unquote a spell. And so these babies actually ended up having longer stays than we would have anticipated in the NICU, and ultimately were discharged home from the NICU instead of being brought back to the nursery. So this is just something to think about, I think, for all of us that are trying to do separation of care in a highly monitored situation with healthy newborns. Next slide. Okay, so then we've had this most recent case. This is as of last week. So we were really proud that we have successfully been able to, work with mothers in this case-by-case shared decision-making approach. But so far, all of our conversations had occurred after birth. So after the mothers had delivered, only then were we able to ascertain whether it was going to be a good situation to put the baby in the room. And we realized that we're really missing the boat a bit here. Our goal should be to have this shared decision-making approach occur before delivery. So we've spent the last week really developing a template to do prenatal consults where we discuss all of these issues with mothers as best as we're able when they're in labor and delivery, just like we do a whole host of other prenatal consults. So we've got that. We are just starting that now. And we also, one issue, at least for us at our institution, is then how to help the labor and delivery nursing team in particular be able to take care of 2 patients that are both under precautions, meaning the mother and the baby after birth for that period of time before they get transferred over to the postpartum room. So it's, again, a logistical issue, which we're trying to figure out how we can support our nurses to be able to do that safely and to help the mothers as much as possible. So I will say case 12 there, we're very happy to see that the baby actually went to the nursery and is still there. So she currently remains in-house. I will say this was a case, though, where mom became a PUI after the baby was in the nursery, but at least this is a time where we didn't then remove the baby right away, but we were able to assess mom's wishes at that time. Next slide. So this is just my final slide on just some other reflections as to where we are in the process and what's happened with our team. First is that the collaboration and communication really are critical. And there's been many services involved. This has been happening. I know this isn't news to the people on this call that are really dealing with this themselves too. So things like, of course, the nurses and the physicians and ID and infection control, but really like audiology or the people that do the circumcisions, like all of these people had to be involved. The pediatricians that are taking care of our families after discharge need to have an actual clinic that can see them in person. So just a lot of coordination on that end too. My second bullet point is you really do have to try to learn from each case right now. Things are rapidly evolving. You know, your PDSA should really be N of 1, like learn from each case and what you can do better. Next is the data tracking. This is really important. I think this has helped us. We're starting to get going with this at our center. We get emails every day about all the positive cases. It first had just a mother page, and now it has a baby page, and now it has an antepartum and postpartum. Like, it's sort of evolved as we've needed it to evolve over time. So please, on your teams, try to come up with a system for tracking at least the basics so you know what's happening to your families and your patients. And again, the equity piece. This has been big for us too. I mean, this is something we do sort of bread and butter at Boston Medical Center, our urban safety net hospital, but literally we've had to use translators. We've had to really think about the cultural beliefs of breastfeeding for these women. And again, this whole idea of the shared decision-making, the equity is really wrapped up in that whole conversation. Okay, I think that's it. Next slide. I'd be happy to take any questions at the end. Thank you.
Thank you very much, Meg. That was terrific. We have a number of questions that have come into the chat box, many for you, Meg, so I'll have you hang on there. I'm going to start with the first question from for the first talk, but first I want to just make a couple of comments. Any questions that you have, I'm noticing people are chatting their questions into the chat box. We appreciate that. Continue to chat them in. We also have a raise your hand feature that you can use. And just know that the slides and resources will be available at 2 websites, both the Betsy Lehman Center and the PinQuin website. Betsy Lehman Center ma.gov and the PinQuinMA.org. Both have links to the site of COVID-19 response or the COVID-19 town hall slides, so you can check those things out there. With that being said, Madge and Joanna, we have a question around how are you addressing families' limited data and time on phones or lack of access to the internet for telehealth? How are you addressing that in your institution?
I'll jump in, Madge. I saw that question, and it's one that we haven't completely figured out, quite honestly, especially in our region. I found that with our advisory council, we've been having to pivot really quickly with quick turn communications and things like that, and some of our advisors don't have reliable internet. So those are the advisors. As far as parents, those who are in the nursery at that time, we do have iPads we let them use. But again, there's a much larger issue about access to reliable internet and data. Madge, I don't know if you had anything you wanted to add to that.
No, I think ideally if the family is at the bedside, then we know there would be high-speed internet, and that takes away some of the technology barriers. And also the nurses or others can help a little bit with navigation and provide some support and guidance and encouragement. But for the families who can't get there, it's harder. There are a couple of communities in New Hampshire who have set up school bus internet stops. So you need a car and you need to be able to get there, but it's a hot spot for Wi-Fi. And I know that some of those sort of innovative things are being tested to deliver classroom to home in those circumstances. But your point is a good one. There's a giant digital divide, and COVID brings out all the weaknesses in our health system and magnifies them, and this is one such weakness.
I completely agree. I just want to say thank you again to Madge and Joanna for a really fantastic presentation. I certainly learned a lot, and it's really important that we keep in mind what we're thinking about in terms of equity and working, like you said, with the patients and families as we're pivoting to change our practices in response to this. So the next question I have for Sarah Ray Easter, actually, is Sarah Ray, in terms of thinking about your work that you've been doing in the ICU, how have you been helping others to think about whether or not there are any concerns related to creating inequities, knowing there have been reports in the media around ICU beds or ventilators available for people based on issues such as payer status or race ethnicity?
I think that's a really good question and a really challenging one. I think the sort of framework set forth regarding sort of the crisis standards of care, very objectively accounts for sort of disease severity, i.e. likelihood of recovery, and then also underlying comorbidities, i.e. sort of potential for life years saved. There aren't considerations, frankly, beyond, those sort of specific, very objective criteria, but the notion of like assigning points to a person and using those points to put a person in a color category and then using that category to sort of triage resources is, I think, fundamentally disturbing to sort of what we do both as clinicians and frankly as people. I think, what I personally have tried to do for my patients is, to remind people that we aren't at that crisis standard of care yet, and to also sort of emphasize that that framework exists entirely separate from my job as a clinician. And I think this is sort of where that distinction between clinical care and clinical operations becomes really important. I am, in this capacity, I'm working to sort of streamline pathways for the care of critically ill pregnant patients. But when I'm at my patient's bedside, I am her doctor. She is my number one concern. And I think, even though that is something that I know to be true, and I think my team members know to be true, the challenge is families can't see that. And I think, if you think about the type of family-centered care, patient and family-centered care we provide on labor and delivery, the ICU setting is exactly the same way, where families routinely join for rounds. They're included in decision-making conversations. They are encouraged to bring in articles from home so we get to know their intubated loved ones better. And I think those personal touches are really lacking. And so ways that we have found to sort of mitigate some of those concerns in the ICU environment actually parallel a lot of the things that that Madge was talking about with respect to sort of developing that framework and really trying to emphasize patient and family-centered care. I think that piece doesn't necessarily ensure equity in the sense that, like in the objective way that sort of point system does, if that makes sense. But I think for patients who have limited health literacy, who may have sort of a very good reason to have sort of underlying suspicion about the clinical or about the sort of healthcare system based on past experience, I think that personal touch actually means a lot. And I have found, there's a lot of gratitude, even though we are perhaps providing a standard of care that we would ideally like to make better, if that makes sense.
It does, that's helpful. There was another question also added to you discussing, I guess, the point system, which is, do you get more points since there's two people at stake here, mom and baby?
Yes, it's very interesting and very controversial. Specific sort of point systems included pregnancy. So the point system that at least Partners Healthcare has proposed, it's like golf. Fewer points is better. So more points are bad. So there's actually a 2-point pregnancy deduction. Sort of that was a very controversial inclusion in this, in that framework, as was the notion of like a healthcare provider deduction, which I think ultimately didn't make it into the final guidelines. And I think, for me, the, that point deduction actually just underscores how important the work that we do is. And I think, frankly, how much, I don't want to say like how much hope our pregnant patients actually offer in an ICU setting. It's incredibly stressful, but I can't even tell you how happy the ICU team is to see photos of, you know, updated from the patient's baby that we delivered this past weekend. And so I think, even that point system is sort of very objective in the setting of pregnancy and perhaps a different, you know, a different framework altogether. I think, you know, it underscores how important the work we are doing in this environment is.
Well, thank you very much. I want to say thank you again for all that you're doing in the ICU and all the, I work with Dr. Easter, for those of you who know, and she's always available and always working and very deep into this. And so I really appreciate all that you've done, Dr. Easter, in this work. With that said, I want to turn our attention to the breastfeeding conversation. There were a number of questions there, and Meg, we have a few of them. Knowing that we have 7 minutes left in this hour, we may not get to them all, but I'm going to take 2 questions and put them together. If you can open up also by commenting on your the NeoQuick webinar and something that might be addressed tomorrow from 12 to 1 when you start to answer. The first question though is just in your first slide, you show how the AAP and other professional organizations have a few different recommendations. When the guidelines aren't clear, the evidence isn't clear, I'm sorry, the evidence doesn't exist and the guidelines aren't clear, how do you best proceed?
So yeah, so the first thing that you mentioned, we have a webinar tomorrow from 12 to 1. And the focus of that is going to be mostly the discharge issues that we're facing. So we have 2 or maybe 3 teams that are going to be presenting there, but just so you guys know, I noticed a lot of my neonatal colleagues on this one. We're going to be discussing a lot of the discharge tasks, if you will, that we do, the CIRCs, the newborn screens, or the hearing screens rather, that kind of stuff. We're going to be discussing how you determine who's a safe caregiver to care for the family at home. We're going to talk about any testing that needs to be happening to the babies post-discharge and handoff. So stay tuned for a lot of those. To go back to the first question, I think we're really stuck. One thing that I would clarify, Audra, about what you said is, I think that the evidence is unclear. I think the language in the guidelines is clear. It just differs. Like, I understand why the guidelines, the wording and what they're implying, I get between the different groups. And I guess I just think it's kind of a different philosophical approach. In the lack of evidence, in an era where there's not evidence about what happens with transmission of COVID-19 to these infants, do you take a very conservative approach, because we know there's other viruses like flu that can pass from mother to infant and infants die of flu? Do you take a very conservative approach and have everyone separated? Or in the lack of evidence, do you say, well, we know breastfeeding is really successful, we know that that is very important. Do you go with what we are currently doing and not change it until we discover that something could be really dangerous? So I've really seen this as like different philosophical approaches to the same lack of data, but it has been making it tough. And
when you're applying those recommendations for WHO AAP, were they intended to apply to known COVID positive moms, known COVID PUI moms, so they have symptoms, or applied to all patients with an unknown status? And I say that now that we know that, for instance, many labor floors as of 2 days ago have started universal screening for COVID on their floors.
Yeah, I believe that these were all written in the context of knowing that the mother was COVID positive or a PUI, not in the era of universal screening. That's been really new in the last week or so.
Yeah, so in terms of shared decision-making about breastfeeding, what information can we offer to help families make the decision? The second part of the person's question was, why did AAP say to avoid direct breastfeeding? Did they cite any data on this?
So in terms of, so for the AAP, I mean, I think it's their whole idea is that, I think the idea there's in the lack of data, and there is concern because of other respiratory illnesses like the flu, for example, and currently we do recommend separating a mother from a baby when she has active flu. The idea is they would want them, if you could do it, for the babies to be separated. And again, the mother would not be directly breastfeeding if the babies were ideally separated. They would want them to resume direct breastfeeding following the mother's resolution of symptoms. And there's very concrete information in the AAP statement about what exactly those criteria are for the mother that constitutes resolution of symptoms. In terms of the shared decision-making approach, I think it's just being honest with the families about what we need, what we know, and what we don't know so far, and understanding what do they value about breastfeeding, how concerned are they about these potential risks, and just trying. That's what I would do. Would just work with them about that. So,
thank you. Were the positive babies isolated or rooming in? Was the question related to the chart you showed with the moms who were COVID positive? And to that point, there was another question that also added in, can you separate the babies without admitting them to the NICU? And so question was around isolating the positive babies, or were they rooming in? And then when it comes to separating the positive babies, can you separate babies without admitting them to the NICU?
So this varies by hospital to hospital. At our institution, we do not have space to have separation of the baby be in the nursery setting. Like, we don't have a huge number of extra rooms for the babies to be separated in the nursery setting. So that is why at our institution, we chose that if they were going to be separated, they would go into an isolation room at the NICU. That's something that just varies from center to center. Yep.
And I'd ask this, that the folks who chatted in questions, some of these questions we can even direct toward you, Meg, separately. Then maybe we can put some question and answer into our resource list, because we have 2 minutes left, and I just want to ask one additional question before we close out. The next question, just in order of the ones I was pulling them up, is how do you treat the asymptomatic partners of COVID positive mothers? Do you consider them PUI? Do you allow them to provide newborn care? How are they allowed to engage in the care with the mom and baby?
That is a tough question. I'm wondering what my other colleagues think. Right now, asymptomatic caregivers at our hospital are literally asked to care for these babies in the room. We know this is continuing at home as well. And it's a very tough situation. Like, you know, we literally are calling these mothers to try to understand what are any caretakers that can help take care of these babies in the home. And for sure, the caretakers are also living in the families, and for sure, a lot of them are asymptomatic and a carrier. So this is why the whole thing is very complex, and it's a little unclear what's the right next step.
That it is 1 o'clock, and we want to thank everyone who has attended for attending this town hall. Next town hall will be same time next week on Tuesday from noon to 1. Please complete the survey linked in the chat box to tell us about your experience with this. You will also receive the survey in the email if you were on the distribution for the town hall series. If you are not on the distribution for the town hall series, please go to this website to also sign up for the town hall series so you can get information on the next dates. I want to say thank you again to all of our speakers for the wonderful information that you're bringing forward. We'll continue to have the questions that weren't answered from the chat with us and help to get those questions answered for folks so that it's available. Just also know that as answers are coming forward, policies and work continues to change. And so those answers might change along the way as well. And just want to say thank you to everyone for joining and for all the work that's happening out there to help take care of our moms and babies during this pandemic. Have a great afternoon.
Yeah, I just wanted to say, we'll keep the chat box open for a couple of minutes if you have additional questions, or if you want to enter your email address so that we can send you a link to the survey. Thank you.